All right, let's just dive right into this explainer. If you're gearing up for your nursing boards, you already know the maternal newborn section is just packed with high-stakes, make-or-break scenarios. Today, we're going to master the absolute highest yield, high-risk newborn complications you absolutely have to know to pass the NCLEX. We're going to strip away all the fluff and focus purely on what actually keeps these vulnerable patients safe and what the exam expects you to prioritize.
Picture this. A newborn is right in front of you, grunting, and you can clearly see nasal flaring. What's your absolute first priority? I really want you to pause and think about this clinical scenario for a second, because honestly, how you answer this single question basically dictates whether or not you grasped fundamental nursing safety. So hold your answer in your head.
Okay, here's the crucial point. Establishing an airway and addressing that respiratory distress, which, by the way, is exactly what that grunting and flaring are screaming at you, always trumps everything else. This is a classic NCLEX trap. They're going to throw distracting info at you like, a low birth weight or some pending metabolic screen. Don't fall for it. Airway, breathing, circulation. Your ABCs are literally your foundational priority.
So why are we hammering this home? Well, because the NCLEX is practically designed to test how you handle information overload. During your real clinical shift, you're going to be bombarded with data, right? In this explainer, we're going to chunk all this dense clinical data into visual memory anchors. By the end, you're going to be able to use pattern recognition to instantly spot what'll actually harm your patient, and you'll be able to seamlessly sidestep those traps the exam uses to trick you.
Here's our cognitive roadmap for today. Substance exposures, airway and sugar priorities, jaundice and metabolic traps, a mini NCLX scenario, and we'll finish with a rapid recap. Let's get to it.
First up, substance exposures, specifically NAS and FAS.
So we've got neonatal abstinence syndrome, NAS, on one side, and fetal alcohol syndrome, FAS, on the other. It's like night and day. NAS is this acute hyper-irritable withdrawal state. You're looking at an infant with an incessant high-pitched shrill cry, tremors, and a wildly hyperactive moral reflex. FAS, though, that's not an acute withdrawal. It's actually the result of the toxic teratogenic effects of alcohol during development in the womb, leading to long-term cognitive impairment, delayed growth, and distinct structural abnormalities. Now, to really lock in those physical memory anchors for FAS, take a close look at this facial structure. The NCLEX absolutely loves to test if you can recognize these teratogenic effects. Microcephaly, so a smaller head, small eye openings, a short nose, and a remarkably thin upper lip. Burning this visual right into your memory is going to save you vital seconds on test day for sure.
Moving right along to airway and sugar priorities.
Okay, so the literal second the umbilical cord is clamped, the baby is entirely on its own to do two huge things: keep breathing and keep their sugar up. 40 milligrams per deciliter. 40. That is your magic number. Hypoglycemia in those first 3 days of life is strictly defined as a blood glucose level less than 40 milligrams per deciliter. Think about it. When that cord gets clamped, the mom's supply of glucose just completely stops. If the baby is stressed out physiologically, they burn through their glycogen stores incredibly fast. Missing this number? That's a massive safety violation because untreated hypoglycemia can rapidly cascade into seizures, permanent brain damage, or even death.
So, when the exam throws that classic "what would the nurse do first" question at you for a jittery or lethargic newborn, remember these 3 steps. 1. Identify those exact manifestations. 2. You gotta measure that blood glucose. Go get a heel stick. And 3. Initiate early feeding immediately. You absolutely have to replace that clamped-off umbilical source of sugar, and feeding is simply the most direct, physiological way to make that happen.
Now let's pivot to airway threats, specifically meconium aspiration syndrome. Here's what happens. When a fetus gets stressed in utero, it can actually cause them to have a bowel movement, passing meconium right into the amniotic fluid. Then, the baby's gasping reflex at birth pulls that thick, meconium-stained fluid directly down into their fragile lungs. This causes severe respiratory distress, and if you throw your stethoscope on them and auscultate, you are going to hear some really coarse crackles. Your immediate #1 priority? Clearing that airway.
All right, major safety alert right here. Do not fall for this extremely common test trap. The NCLEX might describe this big, robust 9-pound baby and then ask you about their respiratory risk. Listen to me. Birth weight alone is not an indicator of fetal lung maturity. Respiratory distress syndrome happens because of a deficiency in surfactant. That's the phospholipid that keeps those tiny alveoli from collapsing. It literally does not matter how much the baby weighs. A large premature baby can absolutely still have critically immature lungs.
Let's shift gears to jaundice and metabolic traps.
So we're shifting focus from the lungs over to the liver and metabolic screenings. This is an area where delayed nursing interventions can literally cause permanent, irreversible neurological damage. The absolute most crucial point about jaundice, or hyperbilirubinemia, is understanding the mechanism of harm. When an infant's immature liver just can't conjugate bilirubin fast enough, you end up with an excess of unconjugated fat-soluble bilirubin. This excess completely saturates the albumin binding sites in the blood. And once those are totally full, that free bilirubin crosses the blood-brain barrier. When levels creep over 25 milligrams per deciliter, it can permanently destroy neurons. We call this kernicterus, and it leads to devastating outcomes like spastic quadriplegia.
To prevent this bilirubin encephalopathy, your nursing interventions are super clear-cut. First, frequently assess the skin and the sclera for any yellowing. Second, support early and frequent feeds. Why? Because conjugated bilirubin gets eliminated in the stool and urine. Basically, the more they eat, the more they excrete. And third, maintain that phototherapy to help break down the bilirubin, right there in the skin.
Let's move to metabolic screens and see how this builds up your critical thinking. Check out how we chunk these two classic metabolic traps, PKU and galactosemia. For phenylketonuria, the baby is missing the enzyme to convert phenylalanine. Without intervention, it just builds up and causes cognitive impairment. The fix? A strict, low phenylalanine diet for the rest of their entire life. Conversely, galactosemia means the baby lacks the enzyme to break down galactose into glucose. The absolute non-negotiable rule here: no breast milk, period. Breast milk contains lactose. They require a very specific lactose-free formula immediately. Otherwise, you're looking at failure to thrive and intellectual disability.
Okay, this right here is a classic visual differential diagnosis you have to know regarding abdominal wall defects. Omphalocele and gastroschisis both involve abdominal contents hanging out outside the body. But here's your memory trick. Omphalocele starts with an O, so think, oh, it's covered. It actually has a thin protective membrane over it. Gastroschisis, on the other hand, leaves the bowel completely exposed with absolutely no covering whatsoever, which just drastically shoots up the risk for bowel torsion, fluid loss, and a life-threatening infection.
All right, time for a mini NCLEX scenario.
Let's put all this pattern recognition we've been building up to the actual test. Imagine you're getting this exact handoff report at the start of your shift in the high-risk nursery. You've got a term baby boy, mom has a documented history of opioid use, and the outgoing nurse tells you her primary complaint right now is that the baby is just incessantly crying.
So, you walk in, you assess the infant, and boom, you immediately notice these findings. The cry isn't just loud, it's this incredibly high-pitched, shrill cry. You note frequent yawning, a respiratory rate of 65 breaths per minute, which remember is tachypneic, a temp of 99.5 degrees Fahrenheit, and a wildly hyperactive Moro reflex. You are staring at overwhelming metabolic, vasomotor, and central nervous system hyperactivity.
I really want you to pause and think here. Based on that maternal history of opioid use and these super-specific, hyperreflexive, tachypneic signs, what condition are we looking at? And way more importantly, what is your most critical priority nursing action? Okay, if you said neonatal abstinence syndrome, or NS, you hit the nail right on the head. And your priority action? You absolutely need to decrease environmental stimuli to prevent seizures, all while continuously keeping a hawk eye on those airway and respiratory changes.
Finally, let's hit our rapid NCLEX recap.
Let's lock all this in and map out your absolute must-know conditions, just so you can walk into that exam room with total confidence. For hypoglycemia, your trigger is a glucose less than 40 milligrams per deciliter. Your action? Feed and check. For NAS, the trap is that shrill cry and tremors. Your action is decreasing stimuli and monitoring those ABCs. For severe jaundice where you're risking kernicterus, the danger zone is bilirubin over 25 milligrams per deciliter. Your action is getting them under phototherapy and feeding to excrete it. And for respiratory distress syndrome, the classic signs are grunting and flaring. Your action is anticipating oxygen and surfactant administration.
I'm going to leave you with this provocative thought to really challenge your clinical judgment as you keep studying. We've talked extensively about airways today, right? Well, if a newborn has a cleft palate, like an incomplete fusion of the palates, how does that structural defect fundamentally change your priority airway assessment and your feeding strategy compared to a healthy term infant? Think about those massive aspiration risks and specialized feeders. Keep chewing on that one, and until next time, keep thinking like a safe, priority-driven nurse.